All right. So we can try, since we skipped last night or last week, we can try to do both respiratory and cardiovascular tonight. If for some reason we need to split it up and still do 2 weeks, we can. But if we can kind of get through all 10 questions for respiratory and cardiovascular, then we will, so that way we can keep on track. Because I know that I had the schedule worked out so that we would finish by the week before Christmas. So let's try to stay on track and just make up some ground for last week that we missed. Obviously, if for some reason we're not able to get through all of them, or there's a bunch of questions and conversation, then we can, what's the word? We can flow cardiovascular into next week. Okay. So let's start out. Number one, we have provider performs a diagnostic thoracoscopy, followed by a thoracoscopic excision of a pericardial cyst. So we have two options that have 3260. So let's go to those and see if we need to report that code. If we do, we've got to we have ruled out two. If we need it, or if we don't need it, then we've ruled out the other two. So for 32601, we have a thoracoscopy diagnostic on the lungs, pericardial sac, mediastinal, or pleural space without biopsy. So what procedures did we perform here? We did do a diagnostic thoracoscopy, right? And then we did a thoracoscopic excision of a pericardial cyst. So if we're doing a diagnostic thoracoscopy and then we're doing a therapeutic thoracoscopy where we do the excision, are we going to report them both? Any guesses? So if we have a scope that we're going in and looking, and then while we're in there and while we are looking at it, we decide to do a procedure, should we report the
Yep.
diagnostic as well as the
Yes.
diagnostic as well as the surgical? My
Yes.
words are not coming out. Okay.
I say
So,
yes.
okay. So Terry says yes. I have some people in the chat that say yes, some people that say no.
No.
So with our scopes, whether they be thoracoscopes, whether they be endoscopies, whether they be colonoscopies, whatever they are, okay? Anytime you have a surgical procedure that's performed with the scope, we are not going to report the diagnostic separate. So that is any body system, okay? That's just kind of a general rule. Any body system, your surgical scope is always going to include your diagnostic scope. So if you look
Okay.
directly above code 32601 in your CPT manual, then you have a little statement there that says your surgical thoracoscopy or your video assisted thoracic surgery, known as your VAT, always includes diagnostic thoracoscopies. So we should not report the diagnostic one
Okay.
separately
Got it.
with the surgical. Yeah, I know that's a little tricky because they will document them both,
Mm-hmm.
but that's just a little trick that we have to remember, a guideline that we have to remember, that surgical always includes our diagnostic. Okay. So then let's go look at 32661 because that's in two options, right? Even though we know that we're looking at the one that doesn't have the 32601. There were two options that have 32661. So our 32661 is a thoracoscopy surgical with an excision of a pericardial cyst, tumor, or mass. Yep. So I've got some people in the chat that are saying that it is letter D, 32661. Yep. Does that make sense to everybody now? So you can see from a testing perspective, they might test you to see if we're going to report that diagnostic separately. Okay. So
Great.
what I like to do on my pages of my CPT, at the top of your page in the margin, anywhere that you have diagnostic scopes, always write at the top of that page, surgical includes diagnostic. So that way it's just another visual reminder to not code them both, and it's one or the other.
Okay. Awesome.
Okay. Any other questions? It's a little tricky, but I always like to include that one just because there's always good practice. Okay. Let's go with number 2. So a patient's nose was hit by a baseball during a high school baseball game. At that time, reconstruction was performed with local grafts. The patient returns now as an adult. He is discontent with the bony prominence along the bony pyramid and the flat look of the nose. He underwent major repair with osteotomies and nasal tip work. So in this one, we don't have 2 options that have the same code, right? We have 2 that are semi-close and then 2 that are semi-close. So let's go look at, let's just do the 30410 since that is numerically first. So 30410 is a rhinoplasty primary, complete external parts, including bony pyramid, lateral and alar cartilages, and or evaluation of the nasal tip. 30435 is a rhinoplasty secondary, and then it is intermediate revision, and it has bony work with osteotomies. Okay. And then 30450 is right there with it, which is your rhinoplasty secondary major revision with nasal tip work and osteotomies. And then your 30462 is your rhinoplasty for a nasal deformity secondary to a congenital cleft lip and or palate, including columnar lengthening. And then it has tip, septum, and osteotomies. Okay, so I've got a couple answers in the chat that we think 30450. So that is your rhinoplasty secondary major revision. And then it includes nasal tip work and osteotomies. So is this a secondary repair? What's our phrase in this condition or in this
It's
question?
major.
It's
Okay.
major.
Okay. But is it secondary? Is it
I
a
would
secondary
say
rhinoplasty?
I wouldn't say it's secondary. Well,
You would
yes,
or
yes, it
wouldn't?
is. Yes, it is. It's secondary.
Okay. So what is it that's making it secondary?
I want to say because of the rhinoplasty, right? The revision of it.
Yep.
I don't know.
Yep. So
Okay.
essentially, he had the reconstruction, let's say it was 10 years ago, right? Whenever he was playing high school baseball.
Oh,
And then he
okay,
comes
right.
back 10 years later, right? So he's now returning as an adult and they underwent the major repair. So this is
Okay.
going to be a second time that they've done it. So it's going to be, the secondary repair. So just because I asked, and this is just kind of a disclaimer. I know some people that are on here know just because I ask a question doesn't mean you guys are wrong. I just want to hear you guys' thought process. So that way, if you were to have a question like this, you're going to be confident and say, I remember talking about this and we talked through it and this is why. So don't ever feel like because I asked a question does not mean you're wrong. Okay. Any other questions? Any thoughts on number 2?
No, I think
Okay.
you were very clear on
Nope.
that one.
Say that again.
No, I said, I think you're very clear. I'm
Okay.
actually trying to highlight as we go along.
Yeah, absolutely. Okay. Number 3, a 43-year-old female is seen in the emergency room with severe epistaxis. She said that this is a common occurrence for her during the cold, dry months of winter, and that's why she's here for the 3rd time this week. Extensive bilateral posterior cautery and packing is again required to control the hemorrhage. So what CPT code is reported for the procedure, and we're not coding the E&M, we're just coding for the procedure that was done. So we have 2 that have 30905. So let's go take a look at that. And I am actually going to delete that because so 30905 is the control of nasal hemorrhage posterior with posterior nasal pact and or cautery, any method, and it's initial. So is this so okay, so I think the letter C's that are in the chat are for this question. Okay. So I have a couple that think we have 30905.
I think it's the 9306 because it's subsequent. She had it before.
Yep, absolutely. 100%. So because she has been here the 3rd time this week, and then again they had to do cautery and packing to control that hemorrhage. Yep. So we're going to use 30906. Now, be careful, and I want you guys to write this note in the book. Okay. So they have this here, and technically, and I've emailed AAPC multiple times about this, and I haven't seen the change of it yet. But they have this with a modifier 50 on 30905. Okay. For 30905 and 30906. If it is the posterior nasal hemorrhage, it is not considered a bilateral procedure, even though they've done it bilaterally. It's already basically essentially the bilateral component is included in the code. So you should not report a modifier 50. So next to 30905 and 30906, go ahead and write no mod 50 next to it. So that way, if you have a test question, that one of them is 30906 with a 50 and one is 30906 without a 50, you know automatically that we should not report your 50 mod. Okay. So 30905 and 06 are already considered a bilateral procedure, and you should not use a modifier 50. So Carmen, there's not a guideline on that specifically. That's just if you look at your 30901 and 03 that are directly above it, then it indicates that in order to report a bilateral procedure, you can use a modifier 50. And this one, there's not that indication. So that's just your reference to know that there's not a modifier 50 used, even if they do it bilaterally. Okay. Any other questions? Okay. Number 4, we have a 20-year-old is seen for 5 transbronchial lung biopsies of 2 separate lobes. 1 biopsy is taken in one lobe, and then 4 biopsies are taken in another lobe. So we have, let's see, we have 3 with 31628. We have 3 with 31632. Okay. So let's go look at the 31638 or 31628. Your 31628 is for a bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, and it's with transbronchial lung biopsies, single lobe. So we do have transbronchial lung biopsies that were done in one lobe, right? So we'll use 31628. Okay. And then we have to account for the 4 biopsies in the other lobe. So then there's a parenthetical note underneath 31628 that tells us to report transbronchial lung biopsies performed on an additional lobe. Use 31632. So let's go take a look at 31632. And that is your bronchoscopy, rigid or flexible, all of that from the same one. And it's with transbronchial lung biopsies, each additional lobe. And you're going to list it separately in addition to the code for the primary procedure. So the main question is for 31632, do we report a single unit or do we report 4 units?
So I had thought it was B
Okay.
because I was reading at the bottom of 31628. It says 31628 should be reported only once, regardless of how many transbronchial lung biopsies are performed in a lobe. And then it says 31632 should be reported only once, regardless of how many transbronchial lung biopsies are performed in a lobe. So that's
Yep.
why I put that answer.
Yep, absolutely. So you have that parenthetical note that's indicating. The other indicator, just in case that note, if you see a scenario similar to this in a completely different code set, right? In your code description, it says with transbronchial lung biopsy, parentheses S. That biopsy or biopsies is your indicator that you should only report one regardless, because whether they do one or multiple, it's going to be included in that single unit of the code. But yes, Lovely was completely correct. Your parenthetical note does state that it should only be reported once, regardless of how many transbronchial lung biopsies are performed in your lobe. Any questions on that one? Okay. Number 5. We have a 25-year-old male presents with a deviated nasal septum, and the patient undergoes a nasal septum repair and submucous resection. Cartilage from the bony septum was detached, and the nasal septum was realigned and removed in a piecemeal fashion. Thereafter, 4O chronic was used to approximate mucous membranes. Next, the submucous resection of the turbinates was handled in the usual fashion by removing the anterior third of the bony turbinate and lateral mucosa, followed by bipolar cauterization. Okay. So we have 2. Nope, just kidding. We don't. I was seeing these and this one, but I was mixing my numbers up. Okay. So we have 2 that are very close, the 30450 and the 30420 and the 30450. Or we can rule it out because we have 2 that have 30140, and then we have 2 that are 30999. So which way do you guys want to go? Do you want to go with these that are listed first that are close? Or do you want to go with your secondary procedures that we have 2 of? Okay. So let's go to 30140. See what our code description for that is. So the submucous resection inferior turbinate, partial or complete. So we had the submucous resection of our turbinates that was handled in the usual fashion. Okay, so our 30450. Does everybody agree that that is what we should use?
Yes.
Okay, so we can rule out C and D. So then let's go look at 30420. And that is going to be a rhinoplasty primary, including major septal repair. And then the 30520 is a septoplasty or submucous resection with or without cartilage scoring, contouring, or replacement with graft. So did we do a septoplasty or did we do a rhinoplasty? Any guesses?
I want to say rhinoplasty. I might
Okay.
be wrong.
No, you're fine. What's making you think rhinoplasty?
Just because of the location of it.
Okay. So the main portion here is we did a nasal septum repair.
Exactly. Yeah, that's
So
what
if
I
we
was.
do a septum repair, that's not a full rhinoplasty, right?
Okay.
So if we did 30420, we're saying that we did a full rhinoplasty, including the major septal repair. But we don't have anything where they're talking about an actual anything other than the procedure on the septum, right? Because the
Right.
bony septum was detached, the nasal septum was realigned, and then it was removed in your piecemeal fashion. And then we moved to the mucous membranes.
Oh.
So we should only report the septoplasty. Does that part make sense now?
Yeah, I
Okay.
think so.
Okay. So again, rhinoplasty is going to be more exterior and interior, whereas your septoplasty is going to be only interior. And then we have to have our 51 on the the submucous resection because it was multiple procedures that were done and it's not an F. Okay. Any questions on that one? All right. Move on to number 6. So we're going to move into the cardiovascular section. So a physician performs a 4-vessel autogenous, 1 venous and 3 arterial coronary bypass on a patient who had a previous CABG 2 years ago, utilizing the saphenous vein, radial artery, and the left and right internal mammary arteries. Okay. So from here, we have, from a process of elimination standpoint, we have 2 that have 33535. Okay. So let's go look at our 33535. And then our 33535 code description is coronary artery bypass using arterial graft, and it's 3 coronary arterial grafts. That sound like what we did? Whereas the 3-4 is 2 coronary arteries, and then 3-3 is 1 artery. Yep. So we have 33535. So we're going to rule out B and C. I'm going to highlight the 3 arterial for the 33535. Okay. So then we have 33510 for this one. 35600 is the same in both. And the 33530 is the same. So the two that we need to compare are the 33510 and the 33517. So let's go look at the 33510. And that is for a coronary artery bypass, vein only, single coronary venous graft. 33517 is a coronary artery bypass using venous grafts and arterial grafts. And it's for a single vein. So are we going to use the 10 or the 17? So do we want to do 10 for vein only, or do we want to do 17
The
for
17.
the 17? Yep. Because, and this is where it gets a little tricky. Okay. So if you have a vein and artery cabbage, you should never, ever, ever use 33510 through 16. That is if you are doing a cabbage with only a vein component. If there's an artery component, then you should use the 17 through the 23. Because that is vein and arteries. And then this is coding for the vein component, right? But if you look at the code descriptions, the 33510 is a vein only, whereas your 17 is using your venous graft and arterial graft. Does that make sense to everybody? So 10 through 16 is only if there's a venous component and not an arterial component. Does that make sense to everybody?
Yes.
Yeah.
Okay. I know that can get a little muddy, so I always like to spend a minute or two talking about that. I have written on the top of that page, vein only, right? And then on the top of 259, I have vein and artery. Now, remember, we still have to code the arterial component separately. It's not included in there, but that's telling us that we did veins and arteries. This is our vein component of that dual procedure. That makes sense? Everybody good on that one? Okay. Number 7. So our physician changes the old battery to a new one on a patient's dual chamber permanent pacemaker. So again, we have ones that are close, right? But we don't have two that are exact. So we have 33212 and 33213. And then we have 33229 and 228. So let's go look at the 212 and 213. So the 33212 is for an insertion of a pacemaker pulse generator only with a single existing lead. The 313 is with existing dual leads. So the key thing in the 33212 and 13 is for it's the pulse generator only. Actually, no. So your pulse generator is going to be the battery, right? So we're changing the battery into a new battery. Okay. So the pulse generator portion is correct, right? But the 212 and the 213 are only for the insertion portion of it. So we know the 33212 would be out because it's not just an insertion. We also removed it, right? Because we pulled one out and then put a new one in. So your 33213 is semi-correct because that's the insertion of the dual leads. Okay. Let's go look at the 33228 and 229. So your 33228 is for the removal of a permanent pacemaker pulse generator with the replacement of a permanent with the replacement of a pacemaker pulse generator. And then it's for a dual lead system, and then 229 is a multiple lead. So I see a couple answers in the chat that we should use the 228. Yep, for the removal and the replacement. Okay. Any questions on that one? So anytime you have a removal and replacement, if we were to go look at the 33233, that would end up being the removal, right? Where the 33213 is the insertion. The 33 would be the removal. So if we ever have a question that has removal and replacement separated out, always look to see if one of the other codes that's listed includes the removal and the replacement in that single code. Okay. Because if you were to report them separately, it would be unbundling. Okay. Any questions on that?
Yeah, is D is an add-on code? Can we code separately?
D is an add-on code. 33228 is an add-on code. Hang on, let me look. Let me double check.
So it has a number by it. It'll have a plus symbol.
Yes, it's got the pound sign next to it, which means that it is a resequenced code. If it's an add-on code, it would have the plus symbol. Correct.
Okay, thank you.
You're welcome. I know it's easy to confuse those, but yes, the plus symbol is the add-on code. The pound sign is your resequence, just meaning it's out of order. Okay. Any other questions? Perfect. So this one is looking at ICD-10. So patient is diagnosed with acute systolic heart failure due to hypertension with CKD stage 4. So we have two that have I-13.0. So let's go take a look at that. I-13.0 is hypertensive heart and chronic kidney disease with heart failure and stage 1 through stage 4 CKD or unspecified CKD. So are we going to assume that causal relationship between the hypertension and the CKD and the heart failure? Yep. So we are going to use I-13.0. Yep. And then I-50.21 is in both, so we don't need to look at that one. So now we just need to look at N18.4 versus N19. So N18.4 is your CKD stage 4, and then your N19 is unspecified kidney failure. Yep, so we're going to go with letter A. Perfect. Any questions on that one? One thing that if you look at your fourth character in your N18 for your kidney disease stages, N18.1 is stage 1, N18.2, stage 2, N18.3 is stage 3. Now you have 3 different ones within that, but at least the 3 indicates that it is the 3rd stage. 0.4 is CKD stage 4, 0.5 is CKD stage 5. So your fourth character will correlate with the stage. Okay. Any questions on that one? Perfect. Number 9, we're going to flip back to CPT. So a PIC with a port is placed under fluoroscopic guidance for a 45-year-old patient for chemotherapy infusion by a physician. The procedure is performed in the hospital. So what do you guys want to look up first?
Three, 6, 5, 7, 1.
Yep. 36571 is in both. So yep. Let's go take a look at that. Well, our 36571 is insertion of a peripherally inserted central venous access device with a subcutaneous port, and then it's age 5 years or older. Does that sound like what we did? A port.
Yes.
Yep. With the port. Yep. A PIC line with the port. Okay. And then should we report the fluoroscopic guidance separately? Is there any mention?
Yes, you'll
in
report it separately because it's not mentioned of the
Exactly. Yep.
chemotherapy infusion.
Yep. It is not mentioned for the PIC placement. There's no mention of ultrasound guidance, fluoroscopic guidance, CT guidance, anything like that. So we can report that separately. Absolutely. So technically, you don't have to go look at the 77001 because we know that's our radiology code. But if you wanted to go look at that to make sure that it was, then you could. Okay. Any questions on that one? Okay. Last one, number 10. We have a maze procedure is performed on a patient with AFib. The physician isolates and ablates the electric paths of the pulmonary veins in the left atrium, the right atrium, and the atrioventricular annulus while on cardiopulmonary bypass. So they're all right there together, right? We've got 5-4, 5-5, 5-6, and 5-9. So really, they're all going to probably be on the same page. So 3-3-2, 5-4, 5-5, 5-6. Yep, they're all on the same page. So 3-3-2, 5-4, that is operative tissue ablation and reconstruction of atria limited. It's a modified maze. 3-3-2, 5-5 is operative tissue ablation and reconstruction of the atria extensive, a maze procedure without cardiopulmonary bypass. And then we've got with cardiopulmonary bypass. And then 3-3-2-5-9, we don't even have to read the code description for 5-9 because that's an add-on code, right? And we can't report add-on codes by themselves. So we know that we did a maze procedure. Yep. So it's going to be the 3-3. It's either the 5-5 or the 5-6 because it's a regular maze, not a modified maze. And then we did do it with cardiopulmonary bypass. So that's going to be our 5-6. So letter C. Okay. I'm impressed. We went through them both with 15 minutes to spare. So did that kind of help ease everybody's anxiety over the cardio section? Just seeing that using your process of elimination you can kind of make it not as intimidating.
Yes,
Yes.
yes, for me.
Yeah.
Actually, I'm really proud of myself because I had this printed. I thought I didn't print this.
Oh, good. Good.
So this was really relieving for me.
Good.
Mhm.
Yeah. Yeah. You may not understand all of the words, right? But more than likely, your code description will match it and you'll have those keywords. So as terrible as that sounds, because I think everybody like sees cardio and their mind just like purges all of the information. I know mine is not my favorite subject. So I know that there's a lot of times that I have to look for those keywords,
Hmm.
right? And just kind of match it up. And I'm able to usually rule out at least two of them, which makes
Yeah.
it a 50-50 chance now, right? Instead of a 25%, we're increasing it to a 50% chance that we're going to get it right. So, any questions, anything just general that you guys want to chat about since we've got about 12 minutes left?
No, I think I'll say I'm actually surprised with myself that I actually did pretty good
Yeah.
answering them.
Yeah. Well, good. Good. And this is kind of the way that it will be broken out too from a testing perspective, because all of the others, are 20,000 is only musculoskeletal, right? 10,000 is only integumentary. Whereas your 30,000 includes respiratory and cardiovascular. And then it includes your lymphatic, diaphragm, and mediastinum and all of that too. But your 30,000 is not going to be 6 questions only on cardio. It's going to be kind of buffered out between respiratory and everything else.
Yeah, I'm literally pleased too that I knew as much as I knew since I kind of had a brain fog.
Good. Yeah. Cardio, I have challenged myself to have the cardiovascular certification by the end of the year.
Oh,
And that is because cardio has never really been my strongest one because I've always just known enough and just kind of skated past it, type thing.
mm-hmm,
But I finally decided that I'm going to challenge myself to fully understand it. And basically, I jumped in feet first and I'm
mm-hmm.
hoping that I get it. So,
Absolutely. What's
um,
funny that you mentioned that is my previous instructor. That's what she is. She does coding for cardiology. So that's
okay.
basically
Yeah,
her big thing. And so she was like stressing. She was like, I can't stress enough because cardiology is a big one, and a lot of
it
people find
is.
it difficult, and you need to learn this and that. Da, 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 da. So
Yep.
she gave us some nice tips and useful information
Good.
as well.
Good. Good. Yeah, it's always nice when you have an instructor that is very, very knowledgeable in cardio because it kind
Hmm.
of helps make it not as intimidating. And I think that's why, like, my cardiovascular knowledge is quote unquote bare minimum. I hate to say it that way.
Mine's is bare
But
minimum too. Even though
yeah,
she pushed it, it still was like,
yeah.
eh.
Yeah, but at least she kind of helps give some of that knowledge, right?
Mhm. She did.
Whereas when I started preparing for my exam, back in 2007, and I've kind of shared this story with a lot of people,
Hmm.
and it's why I'm so passionate about the education space from like making sure that people have the resources. When
Yes.
I was in school, I did an associate's degree, and
Hmm.
my CPT instructor just never showed up to class. So I essentially had to teach myself CPT,
Right.
which is one of the reasons why I just grazed over cardio, you know. And I've never worked with doctors or physicians that are in the cardiovascular setting or on the
Hmm.
insurance payer side where I'm at now. I've never really looked into the cardiovascular space. Just because like I've never been forced to, because
Right.
I've always stayed in the shadows whenever cardio is discussed. And I have made it my mission this year, and I know we're very quickly coming up on the end of the year.
Hmm.
But I have told myself that I'm gonna conquer my fear and not just keep avoiding it. So yeah, I'm gonna be right there with you guys, studying and preparing and stressing and all the things. So don't worry, you will not be alone in it. But yeah, it's just kind of one of those things that when I tell you guys I know how stressful it is to study and work a full-time job, I work essentially two full-time jobs. So, and
Right.
studying and all of that. So I get it. If you have to take, especially with the holidays coming up, if you have to take a couple of days or a week off during the holidays, just because I know some people, the holidays are hard because it's stressful and it's just busy and crazy. And some people
Mm-hmm.
it's stressful because you don't have as much family around. So don't push yourself through the holidays if you feel like you're starting to struggle. Like it's totally fine to take a step back if you need to.
And I think I took a long enough step back. I think I better step in so I can
Yeah.
take the
Yeah, absolutely. And if you're like, I just took my break over the summer and I have to, like, I'm forcing myself to do it, then
Yes,
absolutely.
yes,
Everybody's
yes.
situation is going to be completely different. So,
Mm-hmm.
so yeah,
Yeah, I
I
just
always
had
just
so
like
many
to,
like life obstacles, just like life's
yeah,
been life. And it's like it was one thing, one distraction after another, and a few deaths in the family as well. So I was like, okay, let me get a grip and let me get back into it now.
exactly. Yeah. Yeah. Well, I'm sorry to hear about the death.
Thank you. I appreciate
I know that it seems like when one thing happens, the floodgates open and it all comes
it.
at once. But
Yeah.
hopefully the waters will start to calm in the
Yes.
life and you'll be able to get focused back into it. But
Yes.
yeah,
Well, I'm
just
appreciative tonight the stars aligned because I was able to get
good.
in and I had the printout. Like I am definitely beaming on 100 right now.
You were ready and prepared.
Yes.
Well, good. I'm glad. I'm glad you're back. I'm glad that life is starting to kind of calm down for you.
Thank you so much. It's glad to be back in.
Hi, Tiffany. I have a question.
Yes, ma'am.
There's any spots left for the boot camp? Is this Saturday, right?
Yes, it is this Saturday. Let me double check and make sure because I had a couple of registrations come through today. So let me double check and see what we have available still. Yes, I have 3 seats available.
Okay. So I
Yep.
have another question. So when
Yep.
you have the live boot camp, are we
Mhm.
going to be able to revise that? Like, are we able to have the recording for that to like for a
Yes.
review or just?
Yep.
Okay.
So you will have access to the recording. I think I still have recordings that people from a boot camp that took it like last June. So you'll have access to the recording for the boot camp for at least 12 months. And then it also comes with a 100 question practice exam. And it comes with the ICD-10 annotated guidelines for 2025.
All right. Thank you.
You're welcome. Absolutely.
Hey, Tiffany,
Yes, ma'am.
I just want to say that I am done with the AAPC course and I'm taking my final exam for that on Saturday. And I just went through and watched all of your study review videos from a few months ago. I can't tell you how much they helped me. They were
Good.
awesome. You are a great teacher. And the way that you laid out the medical decision making, the way that you wrote that out in that study course helped me tremendously with that.
Good.
So I want to
Good.
say
I'm glad.
thank you. And I will probably watch them all over again before I take my certification test next month.
Yeah, absolutely. They will be there for you. And then if you want the questions to print out, you can either find them on the Google Drive where everything is housed, or you can find them on the Legacy Education website. So if you
Okay.
want that additional practice to go out and look at it, then you can.
Okay. I just wanted to say thank you because those videos were awesome and you're a fabulous teacher the way that you explain everything.
Well, thank you so much. Thank you. Carmen, one thing I did forget to mention, and sorry, Janine, I didn't want to just kind of like jump from what you were saying to another, but the way that my brain is working, if I don't say it, I'm going to forget it. Since you have passed your CPC exam, then that will also come with 8 CEUs. So that will give you 8 CEUs towards whatever your requirements are for the next year or so.
That's great. Thank you. Yeah.
You're welcome.
I'm newly passed. I'm still
Yes.
learning.
Yep. Yep. But yeah, I didn't want you to forget that is a benefit of it if you are already certified. Yep.
Thank you.
You're welcome. All right. Any other questions? Sarah, was your question about what is it? Was that for what we were talking about with the boot camp? I just want to make sure. Okay, perfect. I was going to say, I saw your question about the cost, but I didn't see the question about what is it until just now. So I wanted to make sure that that's what it was for. Okay. If you all have any other questions, don't hesitate to reach out over the week. Xenia, were you going to ask a question? I think I
Yeah,
just
I
heard you
wanted to. I
come
know I
off
was
mute.
late coming on. I apologize for my
No,
lateness.
you're fine. You're fine.
I was still at work. I was just curious to know with the 225 ICD-10 guidelines, are
Mhm.
we allowed to take those into the examination with us or
You
no?
can't take the printed out version of the guidelines, but you can write all of that information into your ICD-10 manual and bring that in.
Oh, okay. All right.
Yep.
I just wanted to know because I just got
Yep.
them printed, so I wasn't sure if I could actually take the printout with me. Because I
No,
don't
the
have the
printout
2000.
is good for when you're studying because it just kind of
Okay.
helps you see them more parallel versus having to flip back and forth in your book.
Okay.
But from a testing perspective, you're not allowed to bring those additional printed out in, unfortunately. They
Okay.
changed that this year and it was a huge disappointment that they changed it that you weren't allowed to bring them in.
Because I have my 2024 book that you're going to be using versus.
Yeah.
Yeah. Okay. I'll just go through it
Which
and
I
make
will
sure.
say from a guideline standpoint, there was like
Mhm.
one minor addition
Mhm.
to guidelines, but other than that, they're essentially the same from 2024 to 2025.
Okay. That sounds good. Okay.
Okay.
Great. Thank you.
You're welcome.
I have one question, Tiffany,
Yeah.
regarding the same topic. So I did I just passed the CPC, right? And I did
Mhm.
a lot of tremendous work in my both code sets. So if I bring the 2024 and you said there is a minimal changes for the CPT or for the ICD?
For the ICD-10.
It was minimal.
CPT, there's really not. I've seen the new codes that are coming in for the year for 2025. But I won't have any information about guidelines until I get my 2025 manual. But it doesn't look like there's as many changes as there have been in the past from a code standpoint for CPT. So, are you talking about for the anesthesia one that you're going to be taking?
Yeah, because I'm
Yeah.
started
I
prepping.
will. I will say there were no changes whatsoever to anesthesia codes. So I do know that much. So you should be perfectly fine doing the anesthesia, the anesthesia certification with the 2024 manual.
Okay, great. Thank you.
You're welcome. Absolutely. Any other questions you ladies can think of? All right. Well, you guys
I'm
have a,
Thank you so much. I appreciate this. Was so informational for me.
yeah, absolutely. You are very welcome. You all have a great week. Like I said, if you have any questions, then don't hesitate to reach out over the next week. If not, then we will chat next Wednesday. Y'all have a good night.
Good night.